Good afternoon and a very warm welcome to all our audience members to today's Master Series session as part of the World Glaucoma Week, where today we will be talking about perspectives on glaucoma. World Glaucoma Week is an annual observance dedicated to raising awareness about glaucoma, a leading cause of irreversible blindness worldwide. Held during the second week of March, this important initiative aims to educate the public about the risks of glaucoma, its symptoms, and the importance of early detection. With early diagnosis and treatment, vision loss from glaucoma can often be prevented. This week brings together healthcare professionals, organizations, and individuals to promote screenings, share knowledge, and encourage proactive eye care to help protect vision for a lifetime. Our guest speaker for the day is Professor Dr. Gursatinder Singh. And this session is brought to you in collaboration with our dedicated academic partners, the Strategic Institute for Public Health Education and Research, commonly known as Sipher. To lead the discussion and engage Dr. Gursatinder in a very deep and insightful question and answer session, we have with us today President of Sipher, Dr. Rakesh Gupta. Welcome, sir. It's a pleasure to have you with us today. Dr. Rakesh Gupta is the former Deputy Director of NCDs, Director Health Services, and Director of the Chemical Examiner Lab, Government of Punjab, Chandigarh. He completed his MD in Ophthalmology in the year 1989 from Government Medical College, Patiala, Punjab. His awards and achievements include the WHO Award in 2015 on account of World No Tobacco Day. He also represented the Ministry of Health and Family Welfare for a WHO consultation on e-cigarettes in Panama in the year 2016 and on plain packaging in Geneva in the year 2017. He has also won an award for exemplary services in the medical profession by SBI in the year 2019. He has also won an award of honor by the Punjab Red Cross Society as a Chief Coordinator, Pan India COVID Tele Helpline in the year 2021. He also attended the WHO Global Workshop on Flavors and Global Consultation on Novel and Emerging Nicotine and Tobacco Products in Geneva in the year 2023. He also attended the 12th National Thai Conference on Substance Abuse in the year 2023. He has more than 90 national and international consultations organized as the president of Sipher in collaboration with reputed organizations such as DCM, SOPH, PGIMER Chandigarh, the Union, and the Healthy India Alliance. Welcome, sir. Always a pleasure to have you with us. Over to you. You may please introduce our guest speaker for the day and lead the discussion.
So welcome all. So we'll be celebrating World Glaucoma Week from 9th to 15th of March 2025. And we'll have presentation of Dr. Gursatinder regarding perspectives on glaucoma. Next. So what is glaucoma? Actually, glaucoma is a chronic progressive degenerative disorder of the optic nerve that produces characteristic visual field damage. It is the second cause of blindness. Second most common cause of the blindness. World Glaucoma Week 2025's theme is Uniting for a Glaucoma-Free World. It will take place from March 9th to 15th of 2025. And why is World Glaucoma Week important? Because it raises awareness about the glaucoma, since it is the leading cause of the irreversible blindness worldwide, to encourage people to get regular eye examinations to detect glaucoma early, to emphasize the importance of early diagnosis and treatment to prevent the vision loss. Next, please. So we have with us Professor Dr. Gursatinder Singh. He is Professor of Ophthalmology at Adesh Medical College and Hospital, Ambala, Haryana. He is the Medical Superintendent of Adesh Medical College, Ambala, Haryana. He is Professor Dr. Gursatinder Singh is a distinguished ophthalmologist with 38 years of experience in glaucoma and neuro-ophthalmology. And he has an extensive teaching experience, has published more than 15 articles in peer-reviewed journals. He is an active member of the Northern Ophthalmological Society. So you're welcome, Professor Dr. Gursatinder Singh. So we'll stop sharing and then you can share your presentation, please. Thank you.
So thank you, Dr. Rakesh, for the nice introduction. As we all know, we are having a World Glaucoma Week. And as we all know that glaucoma is a blinding disease, it's called silent thief of eye, of vision, because it is a disease which is primarily symptom-free. The only one smart patient may, know what is glaucoma, like he may see he is unable to pick up the objects from the upper drawers, or he can't follow a moving object, and especially like somebody is a golfer, he may not be able to track the ball. So these might be earlier, signs which are normally not picked up. So most of the time, patient would come to know about the glaucoma when central vision starts being affected, which is actually too late in the course of the disease. So the idea is to catch hold of the disease at a very early stage and treat it. It's a treatable condition. That's the first thing I want to tell you. But it's a treatable, and we can halt the progression of glaucoma. But whatever damage has already been there, that cannot be, reversed. So reversal of damage is not possible. So glaucoma, because of the raised pressure, it leads to the damage to the nerve, optic nerve and nerve fibers, and which of course further leads to constriction of the field of vision. That is why patient may start bumping into objects, and those tracking the objects may be difficult. So I'll just go into the what is the scenario here in our country. So if you look at we know that this is the number of people who are suffering from glaucoma, 76 million in by 2020, and number will be 95.4 million by 2030. And only out of these 7.7 million people, that's roughly about 10% have moderate loss of vision, and 11.2 million over age 40 and older are affected by glaucoma in India. This is our situation in our country, Our studies, especially the Andhra Pradesh eye study and other studies, have shown that the incidence is about 1.5%. And the unfortunate part is that most of the glaucoma cases in our country, they're undetected. And it has been seen that at least 90% of cases who are diagnosed with the glaucoma went to an ophthalmologist less for change of glasses or for one problem or another. And to screen all the population for glaucoma is not possible. So the best way to find glaucoma cases is opportunistic screening. That is, when the patient comes to the doctor, he comes for a change of glasses, he comes for refraction, or any other problem, he comes, eye strain, or any problem, you do the IOP and disc examination in all cases. Why I'm saying a disc examination is because 25% cases may have normal IOP despite having a glaucoma. So looking at the disc in all 40 years old and above patients, looking at the intraocular pressure, that's the most important thing. And of course, the extent of blindness is underlined here. 10.2 to 12% of total blindness in India is due to glaucoma, and it is an irreversible blindness. And as I told you, 90% of glaucoma is undiagnosed in our country as compared to only 50% in the developing countries. And 1 billion people worldwide, they don't have any access to the eye care because of the geographical location, or because of not availability, or maybe because of the lack of awareness. And now the thing is that in European African glaucoma cases are mainly open angle glaucoma. And whereas in, China, most of cases are angle clear glaucoma. And in Indian population, almost roughly half the cases are angle clear, half are open angle. Now, what is the difference? I'll just come to you because this is very important to know the differentiation. These are, of course, the activities which are connected last year in the glaucoma. And this year also, a lot of activities are planned under the World Glaucoma Society program. So a lot of activities like lighting the buildings in a green, PD's lighting on the green. Other activities are going on and to be held during the week. And this is a definition of glaucoma. Dr. Rakesh has already expanded on talked about it. So it can be congenital glaucoma, which can present as buphthalmos or with tearing in the eye, or it can be acquired. And anatomically, it can be open or closed angle. And further, it can be primary or secondary to some other disease. For example, it could be secondary to any inflammatory process, or secondary to injury, or any other secondary cause. And we did a study on the glaucoma subtypes. You can see that most of the cases or open angle primary or primary angle clear cases. These are distribution cases. Now, this is a very important diagram. If you look at this, we know we are all born with about roughly about 1.2 million RGCs. That's the retinal ganglion cells, whose axons they form the optic nerve. And this optic nerve transmits the signal to the ultimately to the occipital lobe through optic radiations. And you can see that now there is this is a normally, what happened. I told you we have 1.2 million RGCs, and there is apoptosis. Apoptosis programmed cell death. So acceleration of apoptosis there in glaucoma. There is a once apoptosis there, it leads to cell of the loss of ganglion cells. There is a death of ganglion cells, and of course, there are changes in the retinal nerve fiber layer. And as I told you, retinal nerve fiber is formed by the axons of the ganglion cells. And further, these retinal nerve fibers, as they're being lost, still these changes can't be detected with our, traditional conventional diagnostic methods, especially perimetry. So once you have lost 40 to 50% of the retinal ganglion cells, only then the changes would start appearing in the visual field. That's where we actually can find the structural changes can be seen with the visual field and functional changes. And of course, visual field changes, if there is no the glaucoma is not treated, it will ultimately lead to blindness. And of course, they will be talking about pre-perimetry glaucoma. You can maybe detect some changes if you are doing optic disc examination. That's why I'm saying disc examination is very important to give you an indication there is something happening to the disc. Get the fields done in those cases. That is how you can reach the diagnosis. So as I told you, there is a change in the nerve fiber layer. You can see the nerve fiber layer, they are dying, and you can see, and then the disc changes start appearing. Changes start appearing, but till 50% fibers are lost, you don't have any visual field changes. That is the unfortunate part of it. So you can't detect it at the earlier stage. You have to wait for the changes to progress, and progression has to be there. And this is what the goal of the treatment as per the EGS guidelines. Goal of glaucoma treatment is to maintain the patient's visual function and related quality of life at sustainable cost. So you have to take into factor the economic part of it, financial part. So as Dr. Rakesh has said, we have three kind of treatments available: medical treatment, surgical, and lasers. So medical treatment used to be the mainstay of treatment earlier, along with the surgery. But now in this, like in the last 2-3 decades, we have a new drugs which have come in, which are very efficacious. And now we need surgery only in 5 to 10% cases. Most of the cases, they can be dealt with the drugs only. And we have very potent drugs like prostaglandins, and of course, brimonidine has come up. And we have Rho kinase inhibitors are there. And second is, of course, surgery. Surgery is restricted for those cases who can't come for follow-up, or advanced cases who are not treated with maximum medical therapy. And third is, of course, the lasers. So I refer to a term angle clear glaucoma and open angle glaucoma. So angle clear means that there is a configuration of the anterior chamber angle is such that it leads to raised intraocular pressure. So in these cases, if it is contributory towards the glaucoma, then in these cases, iridotomy is done in all the cases of angle clear glaucoma. That is, iridotomy is we create a connection, create a hole in the iris, which connects the anterior chamber with the posterior chamber, and which is done. So once you have created iridotomy, it behaves more or less like an open angle glaucoma. The treatment modalities remain same. So today in my talk, I should be talk briefly. I'll be touching on the investigative part, briefly on the medical treatment part, and of course, then there is surgical and laser treatment, which I won't be delving too much into it. So this is the goal of the glaucoma treatment. Like as I told you, this is a very important diagram. This is a normal vision, person with a normal vision. So if patient has glaucoma, his vision starts deteriorating. You can see this black line shows that there's a rapid progression, and this line shows there's a blindness, severe functional impairment. Untreated glaucoma will lead to severe functional impairment. If it is treated well in time, you can see that still patient will maintain it retards the progression of glaucoma. Still, glaucoma might progress, but patient will have good functional vision throughout his lifetime. Unless glaucoma is detected somewhere here, even then you can give him good functional vision throughout his lifetime. But if you late in the disease, order of disease, if patient is diagnosed, let's say he is diagnosed with a 0.9 CD ratio or advanced damage, then possibly it may not be able to save the VN, salvage the VN. He may have functional impairment before his death. So idea is to catch the glaucoma early, treat it early, and treat it very aggressively so that the vision remains. Idea is to give him sustainable vision till end of life. This, of course, diagrammatic shows that that aqueous is produced here. From here, it exits through two channels. One is through the trabecular meshwork, other is uveoscleral outflow through the ciliary body into episcleral plexus into the episcleral veins. So there are two exit pathways. One is trabecular pathway, other is through the veins, through the ciliary body, which is called uveoscleral outflow. So how do we control glaucoma? Either we can stop the production of aqueous. That is, we can stop production of aqueous here. Like, for example, brimonidine, timolol, carbonic and hydrogen inhibitors. The three classes of drugs, they decrease the production of aqueous. That brings down the IOP. But there are certain drugs which increase the trabecular outflow. That means they increase the outflow through trabecular meshwork. Pilocarpine is one drug which we have been using for the last like more than 7 decades, 7, 8 decades. And of course, now we have Rho kinase inhibitors, that is netarsudil and ripasudil, which cause dilatation of the relaxation of the trabecular meshwork and dilatation of episcleral veins. They also increase the trabecular meshwork here, outflow. Then we have another class of drugs, newer drugs, which increase the uveoscleral outflow, that is brimonidine and prostaglandins. They increase the uveoscleral outflow. So if I can just sum it up, either you can decrease production of aqueous with timolol or brimonidine or carbonic and hydrogen inhibitor, or increase the outflow with some other drugs. So this is how we control glaucoma medically. And if you want to do a surgery, in surgical part, we create an alternative channel of exit of aqueous in this area, which surgery is called trabeculectomy. Or now we are putting some shunts, micro shunts there, which are inserted in the trabecular meshwork area, which increase the outflow. And this is surgical aspect. And I have referred to the iridotomy. Now, in angle fluid glaucoma, this is the angle of the anterior chamber, this one. It is bound by iris and cornea anteriorly. This is the angle. So if the contour of iris is like this, if its contour is anterior, then the angle is narrow. So because of crowding of the iris in the angle and the pupillary block, IOP rises. So you create an opening here. You create this posterior chamber where aqueous is produced. You join it with the anterior chamber by creating an opening in this area, which is called iridotomy. So once you've done iridotomy, then chances are it will behave more or less like open angle glaucoma, and you can treat it medically. So how we diagnose these are various modalities. I'll just briefly come into this, but the important thing is you have to know about the histrobronchial asthma or obstructive airway disease, because beta blockers cannot be given to these patients. Similarly, patient with second, third degree heart block or congestive heart failure, again, beta blockers are contraindicated under these situations. And of course, then diabetics, again, the beta blockers may mask the effects of hypoglycemia and dyslipidemia and renal lithiasis, renal disease, and dysautonomia, pregnancy, lactation. So you have to take a history because especially pregnancy and lactation, some of the drugs that are contraindicated during pregnancy and lactation. And let's say a patient is systemic hypertension, he's on beta blockers and taking oral beta blockers. So these patients probably may not benefit much from the beta blockers. Evaluation, these are various methods. Tonometry, as we all know, is taking intraocular pressure. And the ideal, of course, the gold standard is this is GAT, Goldman's Apprenticeship Tonometer. So this is what it is. You apply a prism to the cornea, and this takes the pressure, and pressure reading is shown here. So this is the gold method of taking that we use as a glaucoma specialist, and all ophthalmologists should be using this Goldman's tonometer for intraocular pressure. So look at the disc. I'll just show you a few pictures. These are stereo images, stereo photographs. So you can see them as once you fuse these two images into one, you can see the depth. You can see excavation of the cup is there. And then, of course, look at the disc hemorrhage. You can see a small disc hemorrhage here. This is also called as Drance hemorrhage. They are more common in normal tension glaucoma. So I just want to introduce another term here, normal tension glaucoma. As I told you, 25 to 30% patients may have normal intraocular pressure, but still have cupping of the disc and visual field effects. We label these patients as normal tension glaucoma. So, and these hemorrhages are more common in that subset of patients. And in normal glaucoma also you can have. Then there's something called as, if you look at the discs, you can see these two discs look very similar. This is the cup. This yellow part is a cup of the disc, and this is the neuroretinal rim. Now, what happens in glaucoma is because of the increased pressure, there is a posterior bowing of the cup. That means that this cup, this yellow portion, which is this is a cup, this gets deeper, and this is the pink is the neuroretinal rim. If you see, these are the nerve fibers which are running, coming from the retina and forming the optic nerve. So with glaucoma, there is a damage to retinal ganglion cells, damage to nerve fibers, which leads to thinning of the neuroretinal rim. So these two discs look similar, but if you look at this, there is a thinning of neuroretinal rim here and here also. So this is a glaucomatous disc. So you have to, this is how we look at the disc and find out what is going on. And of course, there can be beta zone atrophy and alpha zone atrophy, which are again seen in glaucoma cases. And then, of course, this is an advanced cupping that you see. You must have heard, all MBBS students have heard about, bayoneting sign. It's a bayonetic sign, nasal shifting of the vessel. So these all things are seen in advanced glaucoma. Again, you can see a disc hemorrhage here, Drance hemorrhage. So optic disc size can be measured with a direct ophthalmoscope, like 5-degree aperture of direct ophthalmoscope. So all physicians also have these ophthalmoscopes nowadays. And of course, if it covers a disc, it's a normal size disc. So you can measure it too. Be cautious in myopic disc. Looks like this, it's a pale disc, but you have to demarcate the margin of the disc in these cases. So it's important to look at the disc in totality and as a whole. So once you can see that this retinal nerve fiber layer thinning is there, you can see this area is more dark in color. You look at this vessel, this is darker than this vessel. If you look at this vessel looks much darker. So once there is a RNFL thinning is there, now this vessel is denuded, like this vessel denuded of the retinal nerve fiber layer. So it looks darker in color. This area also looks dark. We call it a wedge defect because of loss of nerve fibers. Then pallor, of course, pallor is not a sign of glaucoma. If you have a pallor like this, That is a sign of optic atrophy rather than glaucoma. Then, of course, there's a nerve fiber layer examination. And you can see these are the normal nerve fibers that we see. And this is, you can see there are no nerve fibers. This RNFL is missing in this area. Now this is, okay, I'll just go to the, and of course there's a gonioscopy, another procedure we do. These are the lenses we use for gonioscopy, but you can see that these lenses, you can see the angles. So you can see the angle structures here, different structures are shown. I've already told you iridotomy in all cases. So this is you can see angle, closed angle. You can't see any angle structures here. Again, you can't see any structures here. And of course, in squeezes per triple mesh, how we differentiate with the gonioscopy between the open angle and the closed angle. So these are the synechia, adherence between the iris and the cornea, which we see in angle fluid cases. So we do gonioscopy to read through these slides. And pseudoexfoliation is another condition which can be present as glaucoma. So you can see these pseudoexfoliation on the lens, and you can see this whitish flaky material on the caps, pupillary margin, which is a pseudoexfoliation material. And again, in these cases, this is you can have heavily pigmented temporal meshwork, and Schwalbe's line and temporal meshwork is seen. So idea is to just tell you that open angle and closed angle have to be diagnosed, and angle fluid cases have to be dealt with iridotomy. And this, of course, pigmentary glaucoma. You can see this pigmentary line here, and you can see pigmentary temporal meshwork on gonioscopy. I'll quickly go through these slides because I can come to the treatment part. And then, of course, perimetry. Then once we've done disc examination, gonioscopy, next thing is we do the perimetry. So this is a picture from the Galapagos Island. We all know Galapagos Island, where Darwin did his experiment in natural selection. And you can see this is like if I compare it to the visual field, it's an island of vision surrounded by sea of blindness. This is how it has been defined. So if I can say this is probably let me see, this is the fovea, which is area with the highest sensitivity. And of course, there is a blind spot. And of course, the areas of these areas, troughs and ridges. So they are the scotomas. So normally it would be, visual field would be like this. So these are holes in the visual fields are scotomas, and the deepest hole is the blind spot. And these are the different machines we use for perimetry. So this is the normal visual field. If this just you can see this is a blind spot. So this yellow one is a normal visual field, and normal visual field is depressed if you have cataract is there, or if there is any corneopathy is there. But if you look at the glaucoma, there are holes in the field of vision. You can see scotomas develop, which are picked up by perimetry. So the idea of perimetry is to pick up the holes in the visual fields. So there are different kind of visual fields we do. There are different kind of we take. I won't go into the interpretation of the visual field, which are beyond the scope of today's talk. So, but generally, if I tell you this is what visual field looks like. So this is actually what you call, these are small dots are the scotomas, so few holes in the field of vision, which I showed you in the diagram. So now you can see this is central visual field. So central 24-degree visual field. And you can see these black spots, they are the scotomas or holes in the field of vision. And this is, of course, we call it arcuate scotoma. This is a nasal step. And these are also isolated scotomas in the visual field. So this is how we come up, once we see the visual fields. If we have seen that the disc looks suspicious, visual fields show some scotomas like this, And if you look at the fundus, there is nothing contributory towards it. For example, retinal damage, retinal like degeneration can have such scotoma. So you make sure retina is all right. This is glaucomatous, and you correlate with these findings. That gives you diagnosis of glaucoma. Once you've done this, then we have a new tools. Of course, you can see the disc. You can see the vertically large cup is there. The thinning is there here, and you can see a scotoma here corresponding. And this again another case of advanced glaucoma. You can see. So this is all scotoma spherally corresponding to this inferior thinning. Superior disc looks to be relatively better. So I am skipping this slide, but I think I want to keep it very concise. And these are now we have some techniques which can image anterior chamber as well as the retinal nerve fiber. They can see the retinal nerve fiber thickness can be seen. So this is a basic principle of optical coherence tomography. OCT is one machine which can tell you about the thickness of the retinal nerve fiber layer. It can see the macula, see the thickness of the RGCs and internal limiting membrane. There is a light source. So light goes to beam splitter and it goes in the eye, and one part of beam goes to the reference mirror. So these two go to the detector. So this delay in these two tells you about the picture. So this is an anterior segment OCT. So where you can see the angle. You can see the angle is closed here, which I was referring to earlier in angle fluid glaucoma. And see there is another picture. You can see this is you can see iridotomy is patent. As I told you, iridotomy is done in angle fluid cases. You can see patent iridotomy. So this technique is nothing with UBM, ultrasonic biomicroscopy. But here the one we use is 50 hertz. Or you can do it with the ocular coherence tomography. Both can be used. And of course, this is following the trabeculectomy. This tube has been put in anterior chamber. So you can put a tube in the anterior chamber to drain the aqueous out. This is what has been done. Then, of course, I told you UBM ultrasonic biomicroscopy. Again, you can see the anterior segment with this. Now, this is the, normal angle. This is cornea, iris, and lens. You can see these structures. Anterior segment can be seen. You can see a cyst of the ciliary body here, and you can see adherence between iris and the cornea here. And of course, it can tell you can see a focal cyst in here with UBM. So, anterior segment OCT and the UBM, there are two technologies which can be used to delineate iris, cornea, and the ciliary body. Then there's another technology, pentacam, which can tell you about angle. So you can see that angle can be delineated with this also. This is another technology. Then, of course, these are structures that we see in the angle, Shorvill's line, trabecular mesh, and scleral spur. So you can really see the anterior segment. If you want to see the angle, you can do it with the gonioscopy. You can do it with the anterior segment OCT. You can do with the UPM, or you can use pentacam. These are four technology ways you can see anterior segment. And then, of course, this gives an analysis of the retinal nerve fiber layer. So you can see that you can see the thickness of the retinal nerve fiber layer around the disc. So this red shows there is a thinning of retinal nerve fiber layer. This is called ocular coherence tomography. So you can see the thinning here. So you can see the thinning of retinal nerve fiber layer, which is a hallmark of glaucoma, superior and inferior thinning initially. And you can do the sequential maps of RNFL and find out the progression of the glaucoma. You can see a progression is there in the damage. So progression can be monitored with this. And the new thing we are doing is we measure the thickness of ganglion cells, because at the end of the day, I told you we have 1.2 million RGCs which are damaged in the glaucoma. So now you can actually quantify the damage of ganglion cells in the macular area. So you can see this is a normal retinal ganglion cell thickness, and you can see there is a thinning here all over except in this area part of the pie. So you can measure, and even this you can see there is a, like this yellow shows this a normal retinal ganglion cells. You can see this red yellow is missing. It's more blue. So you can see thinning. So retinal ganglion cell thinning in macular area can be measured and quantified. I think I'll briefly touch on the management. So if I look at the diagnostics, you examine the disc, do the intraocular pressure, do the gonioscopy, do the OCT for evaluation of retinal nerve fiber layer and the macular thickness. They are analyzed, and then you set up how much IOP loading is required depending on the damage that is. If the damage is less, you can see cup is small, you can bring the IOP down to 18. If damage is advanced, you can bring it to 15, or if it is a very advanced, 12. So the idea is to bring the IOP less than 18 in all cases, whether with the medical means or with surgery. So this is one case which was, asymmetrical glaucoma, which we treated. And you can see OCT shows there's a thinning here, the thinning of retinal nerve fiber layer. So this is retinal nerve fiber layer thin around the disc, which is thinned out. And we treated it with the prostaglandins, and she's stable now. So another case, you can see 70-year male, and he has got vertically CD 0.85 is the CD ratio, and other eye is 0.6. It's again angles are open, so it's an open angle glaucoma affecting mainly the right eye, and you can see on ocular coherence tomography, left optic nerve is normal, right is showing thinning. So we treated this case for the right eye. And of course, this is a visual field. You can see the scotomas in the right eye. And this is another case. You can see there is a case with the high IOP, and you can see a wedge defect here, which I told you looks as a very dark area with the vessels which are very bright. And you can see there is a scotomas on the visual fields. And so I skipped the cases. I think let me come to the final part of my talk. So how should we approach the case, So this is another case. You can see isn't rule is maintained. It's a normal. So what the normal eye looks like. So we have to be number one sure that this case has glaucoma. We do all the tests. Then we quantify the damage with perimetry and OCT because we want to follow up the case. So you have to have a baseline test which are reliable, are reproducible, and then have the baseline test, and then of course proceed with the treatment. And the medical treatment, I won't go in detail except that I told you there are certain drugs, like these are various drugs available. And the beta blockers, I told you, can't be given in obstructive airway disease or in cardiac patients or with patients having heart blocks, avoid in asthma, obstructive airway disease, and CHF, heart block, diabetes. These are contraindications. So I think with this, I end the talk because I don't want to delve into detail. I'll open to the questions. So the treatment is you give beta blockers, you give prostaglandins, we have brimonidine, we have rho kinase inhibitors, and multiple tube of drugs available. So how we start the treatment, we start with one drug only. Mostly we will like to start with a beta blocker or prostaglandin analog like letnoprost, bimetoprost, trevoprost. Start with one drug. If drug is not effective, then switch to another drug. And switch to another drug. That means if your patient is on prostaglandin, start with beta blocker. If patient is on beta blocker, then I think we should start with the prostaglandin. If one drug doesn't work, start with two drugs. And then, of course, you can give 3 drugs at a time. So maximum drug therapy you should be giving in 2 bottles to the patient. 2 bottle means we can have combination drugs. Like for example, we have beta blocker with brimonidine, beta blocker with carbonic anhydrous in it like dorzolamide, beta blockers with prostaglandin. So one bottle you can give as a combination and one other drug. So mostly we restrict ourselves to 3 drugs, maximum in 2 bottles. And if that doesn't work, then we can go to the surgery. Surgery can be in the form of trabeculectomy and tubes. So I think, Dr. Kesh, I think I should stop here. I've taken enough time.
Yeah.
The
And Dr. Gursatinder, I think it was an excellent presentation. And you showed a lot of graphs and photographs to make it clear. So general ophthalmologists and general physicians will benefit from the talk. Thank you.
Thank you very much.
So you can stop sharing and then we can keep talking. So I'll be summarizing Dr. Gursatinder's presentation. The goal of the glaucoma treatment is to maintain the patient's visual function and related quality of the vision at a sustainable cost. So that is our goal. And it is rightly said as a thief of vision. The glaucoma is a thief of vision, but it is treatable if we halt the progress of the glaucoma. And it damages optic nerve fibers and constricts the field of the vision. It is called as the pipe-like vision is there because it constricts the field of the vision. And it is very interesting that 2 million of people, they suffer from glaucoma in India who are more than 40 years. And 90% of glaucoma is undiagnosed in India. So I think rightly said that opportunistic screening is required. So every patient coming to a doctor, to an ophthalmologist, general ophthalmologist, he must be screened for glaucoma, right? And 50% in India, they are open angle glaucomas and 50% are angle closure glaucomas. So that is very interesting to note that a surgery is required only in 5 to 10% of cases. Rest all are treatable with the medicines. So the medicines are quite effective now. And the diagnosis is by the slit lamp examination. So we need to examine the angle of the anterior chamber, and all he told that very very nicely he told about the angles by showing diagrams, and if the medicines like timolol, then pilocarpine, then brimonidine, and letanoprost, etc., they can be used in different cases, and we need to see the side effects of these medicines also and where they are effective actually. So nice presentation, Doctor. And you told about the equipment you need to actually diagnose the glaucoma, like automated perimeters, then UBM, that is ultrasonic biomicroscopy, ACOCT, then HDOCT. So that is very interesting to know. That Pentacam is an added advantage if you have that as a glaucoma specialist. So thanks a lot, Dr. Gursatinda, for a nice presentation. And we'll move to Dr. Manisha. Dr. Manisha, do you have any questions for him?
Thank you so much, Dr. Gupta and Dr. Gursatinder, for that very insightful presentation on the various perspectives of glaucoma, its clinical presentations, the symptoms, and how it can be treated. We do have a couple of questions for you, Dr. Gursatinder, from our audience members. So without further ado, the first question that I would like to ask you is, what is your perspective on how glaucoma management differs in children, especially in cases of congenital or infantile glaucoma?
So most of the congenital and infantile glaucoma, they need to be surgically managed. So if you want to treat them like congenital glaucomas, the only option is surgery in these cases. But if they're waiting surgery, then we have to take certain precautions, like brimonidine is contraindicated in children, and timolol can be given in a smaller strength. But most of the congenital glaucomas would need surgery because they had some sort of aberrations or in the anatomy of the anterior segment, and which has led to this. And then if there are juvenile glaucomas, of course, more than 7 years of age, most of the drugs can be given to those patients.
Thank you for that answer, sir. Moving on to the next question. What are the signs of glaucoma progression and how should it be monitored over time?
Glaucoma progression is like I told you, it's just like what you do in examination. Number one is the disc photographs. So you can make disc photographs or stereo disc photographs. The one important thing is that I'm often asked is that anybody is sitting in the periphery, he doesn't have access to perimeter, he doesn't have access to OCT. What should he do? So, of course, the ideal is to get at least the perimetry done. I don't always say perimetry is a better modality of uh, following up the advanced glaucoma cases. And but in case you are in periphery and the patient doesn't want to go for perimetry, don't get disheartened. Have a close look at the disc. If you can't even photograph disc, make a line diagram of the disc. So even that has sometimes a very good idea of what kind of a disc is there. Draw the disc, draw the cup, draw the contour of the vessels on a freehand drawing, and I think that can be kept. Otherwise, ideal is stereo photographs to follow up the patients. And second thing is to do the sequential perimetries. Because initially we do about 3 perimetries because one perimetry is never reliable. It's a sort of once you have 2 perimetries, which are of course the same kind of a picture is there, which is a sort of a same kind of a perimetry, repeat perimetry is there. Then you go ahead from there and you repeat the perimetry depending on the damage every 6 months to 1 year. And third thing to follow up is the OCT. So you can do the OCT evaluation. OCT is good for in early glaucoma, but it has no use in very advanced glaucoma. But perimetry is very useful in advanced glaucoma. So advanced glaucoma follow up only with perimetry. Moderate glaucoma, you can do perimetry as well as OCT. And of course, the disc photographs and disc examination. If you don't have anything, have meticulous, good examination technique and learning how to examine disc is most important.
We have a lot of clinicians and mid-level practitioners who are watching today's session, ophthalmologists per se, and of course, a lot of general practitioners. So from your perspective or from a community perspective, how do you address non-compliance or poor adherence to glaucoma medications in patients? Is there a way out?
Actually, you have touched a very raw nerve of mine, because the patients, when they're coming to the doctor, most of the time they would have used 1 or 2 extra drops, so that they are sure that their IOP is normal when he comes to the doctor. Checking the compliance, the different methods. So what I do is normally is ask I know, okay, like for example, prostaglandins of good companies would last for 3 to 4 weeks. So if patient says I'm using this bottle in 2 months, or how many bottles he got in a month or 2 months. Similarly, brimonidine, patient would need two refills every month. So that is how I check the compliance. I ask him how many bottles you needed this month. So IOP is not a good predictor of what patient has been doing at home. So ask him how many refills he got. Of course, once you see there is a rapid progression is there in the visual fields or OCT, it could be because of non-compliance. It could be because of non-adherence to the treatment. And then, of course, you got to address it. And could be factors other than glaucoma.
Thank you. Thank you so much for those very meaningful clinical tips and practical tips. I'm sure they must be of help to our audience members watching this session today. Thank you so much. That would be all from our end. We would like to extend our gratitude to Sipher for helping us put together this session. Thank you so much, Dr. Rakesh Gupta, for your guidance and for your support. Thank you so much to our guest speaker for the day, Dr. Gursatinder Singh, for your expertise and for sharing some valuable insights on glaucoma and how it can be prevented. To all our audience members, thank you so much for your active participation in today's session. If you have any questions, please feel free to drop them in the chat box below and we will get back to you with the responses after consulting our experts. Thank you so much and see you around.